Morning is Phil Clements again. He's going to speak on the treatment of Scleroderma 2010.
Okay, this talk is going to be a nuts and bolts talk. It's based in part by some recommendations that I was fortunate enough to be part of the committee that made these recommendations. It's now published in Annals of Rheumatic Disease last year. 3 fellows and junior faculty spent a year digging out all the randomized controlled trials, all the longitudinal trials, and picked the brains of experts. So this actually gets at what I see in the office. Either the patients come or their physicians refer them for the problems we're going to talk about today. Now, we talked about interstitial lung disease and PAH this morning. We'll talk now about Raynauds, digital ulcers, diffuse skin thickening, renal crisis, and the gastrointestinal tract. Again, just a reminder of what's diffuse and what's limited. So we'll start with case 3, a 27-year-old female with Raynauds and 2 new fingertip ulcers. She's had a 4-year history of what sounds like Raynauds. She is a non-smoker and is otherwise healthy. The rheumatologic review of systems is negative. In the past 2 months, she has developed painful sores and black spots on the end of her fingers. And I think you can see in the illustration, this one really hurts. This one is black but hasn't quite come out to be as black as this, but these are very painful and are a real source of agony for patients. Her fingers also appeared puffy. The remainder of the exam was unremarkable. CBC chemistry is normal. Her ANA was mildly positive. I'm not going to go into the differential of Raynauds phenomenon. Fred Wigley did this 8 years ago in the New England Journal, and it's still a good article. It's the approach to evaluating somebody who walks in with Raynauds phenomenon. I refer you there. This page is in your handout. Since this patient has puffy fingers, Raynauds, and digital ulcers, she has secondary Raynauds phenomenon. Definition of primary usually involves the onset of Raynauds in menstruating women who are in their late teens and early 20s. That's when it begins. Nail fold capillaries are normal. Their whole life they go along with wearing gloves. When it gets chilly, they don't have end organ problems. Their fingertips don't fall off. This is primary. This woman has digital ulcers and other problems, and she has secondary. The borderline positive ANA would suggest that maybe there's a connective tissue disease, but I should warn you that 1/3 of the population that you test with an ANA is going to be positive at 1 to 40 at any given time. By the time you get to 1 to 160 and 1 to 320, you're much more limiting and actually working in the area of thyroid disease or connective tissue disease. Now what this woman now needs is nail fold capillaries to be examined and some Scleroderma specific antibodies. It doesn't take $10,000 or $20,000 to do this, although some labs do it that way. I prefer a 10-power microscope eyepiece. Roy Altman taught me that years ago. You could use an ophthalmoscope, you can use a dermatoscope that the dermatologists have for $100, or you can use a jeweler's loupe. Anything that magnifies what's going on in the distal finger. Now, if you've got immersion oil, that's great. Most offices don't, so I use Lubifax. And put it right here near the cuticle and proximal on the finger, and then look. Now what you would like to see is what appears to be kind of a picket fence of pink lines coming down to the cuticle. Not every normal individual has those. I don't. I have capillary loops that kind of come to the surface, and I have a red dot. the kinds of things you're looking for jump out. They look like this or this. Here we have some loops that are dilated, and it looks like there's the eye of a needle. You don't see that very often in normal fingers. The eye of the needle is often a tip-off. Now, the other factor is there's ischemia or loss of capillaries. It's called capillary dropout. What you have is a fair density of capillaries here, and you come here, and they're a third maybe, or even less capillaries still left, and the ones that are there are abnormal. Now, scleroderma and dermatomyositis are about the only two diseases that can do this. Now, if you see a young person and you wonder about muscular dystrophy and you find large capillaries, this is not muscular dystrophy. I have recently become finally convinced that autoantibodies are useful. Years ago, all we had was anti-centromere and anti-SCL70, and that picked up about 25 or 30% of the patients, and I thought I was a better clinician than that. So now we have 5 that are pretty much available throughout the United States, as far as I know: centromere, anti-SCL70 or anti-topoisomerase, anti-PMSCL, polymyositis, scleroderma overlap. The newest one, anti-RNA polymerase 3, anti-RNPU1. I get confused between 1 and 3, but this is the old style that we're used to using for mixed connective tissue disease. The ones that are not so available are anti-THTO, small group of limited patients with bad lung disease, and anti-fibrillary, U3-RNP, small group, mainly black people with bad lung disease. If you screen with this panel, often the phenotype is pretty clear, but I take care of a couple of lab techs at Quest Lab, and for reasons that are far beyond me, they did an ANA panel and came back with SCL70. So you have to look at the patient. These women are normal, but sometimes the phenotype does fit the antibodies. Anti-centromere tends to be people that have Raynauds Phenomenon, limited cutaneous scleroderma. They do wind up with a risk for pulmonary artery hypertension, but they get virtually no pulmonary fibrosis. On the other hand, the topos, diffuse, skin disease, pulmonary fibrosis is a big problem. And yes, they get renal crisis. And there are a couple of other examples in your handout as to what the key pieces are here. The nice thing is that these antibodies are virtually always mutually exclusive. You look at large series, less than 1% will have more than one antibody. So that makes it nice. So if you take the 5 most commonly available antibodies, 58% of the patients will be identified. And there is some prognostic kind of significance as long as you don't lose sight of the patient. And that's easy to do sometimes. You've got to watch the patient in addition to the lab. Now, if you had access to the other 2 antibodies, THTO and anti-fibrillary, you're up to 67% of the population. Still leaves a third unaccounted for. So in this case that I just presented, which of the following is the most appropriate initial management for this patient? Is it aspirin, nifedipine, prednisone, angiotensin receptor blocker, or avoidance of cold stimuli? The exercise will be the same. You pick one you like, and I will slowly remove the ones that I think are less helpful here. There is virtually no evidence whatsoever that aspirin does anything in scleroderma. If you want to protect your male patient from heart disease, be my guest. It doesn't have any place, as far as I know, in randomized controlled trials in scleroderma. Angiotensin receptor blocker, Kosar in particular, has been shown to reduce the symptoms, the color changes, but there's no clear evidence that it improves ulcers. Avoidance of cold stimuli is something everybody with Raynauds phenomenon should do. Prednisone, much overused. The most common use is musculoskeletal pain in a dose less than 10 milligrams a day. Occasionally myositis comes along and you might want to use higher doses. Not in this case. This is not vasculitis. 1% of patients with scleroderma will ever develop inflammatory vasculitis. I fed a